السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله وعلى رسول الله سيدنا محمد وعلى آله وصحبه أجمعين. ضيوفنا الكرام، السيد رئيس الجمعية الأوروبية للأشعة، السيدات والسادة رؤساء الجمعيات العربية والعالمية للأشعة، أساتذة وأطباء الأشعة، تقنيي الأشعة وأخصائي الفيزياء الطبية، الإخوة والأخوات الأطباء المقيمين والطالبات والطلاب، بأجمل عبارات الترحيب أحييكم جميعاً وأقدر لكم مشاركتكم معنا. وأود أن أرحب خصيصاً بضيوفنا الأفاضل من خارج مدينة جدة ومن خارج المملكة العربية السعودية، وأتمنى لهم إقامة سعيدة في مدينة جدة عروس البحر الأحمر، وأن تتاح لهم الفرصة للاستمتاع بالمناظر الخلابة في هذه المدينة الجميلة، وكذلك المشاركة في النشاطات الاجتماعية التي وفرها المؤتمر هذا العام. سوف أقدم ظهر هذا اليوم نبذة عن الجمعية العلمية السعودية للأشعة وعن مختلف الأنشطة العلمية التي يوفرها المؤتمر هذا العام، وذلك خلال الافتتاح الرسمي للمؤتمر. أما الآن فأتقدم بالشكر الجزيل لرؤساء الجمعيات الأشعة كافة على مشاركتهم وحضورهم، وكذلك لزملائي أعضاء اللجنة العلمية واللجنة المنظمة، والشكر موصول للشركة المنظمة للمؤتمر وكافة الشركات الراعية لنا. وبمناسبة كون شهر أكتوبر هو شهر التوعية بسرطان الثدي والتشخيص المبكر لهذا المرض، فسيكون تشخيص أمراض الثدي هو المحور الرئيس لمؤتمر هذا العام، وسيكون لي الشرف ولزملائي أعضاء الجمعية بتكريم مجموعة من أوائل أطباء الأشعة في المملكة العربية السعودية الذين وضعوا أسس تشخيص هذا المرض في المملكة، وكذلك تقدير نخبة من المهتمين بعلم وطب الأشعة. في النهاية يشرفني أن إعلان انطلاق أعمال المؤتمر 12 للجمعية العلمية السعودية للأشعة، راجية لمؤتمرنا التوفيق والنجاح في كافة أنشطته من محاضرات ومناقشات علمية وورش عمل وندوات، وكذلك المعرض المصاحب. وفقكم الله، والسلام عليكم ورحمة الله وبركاته. In the name of God Almighty, Your Excellency Dr. Boris Berkelchich, President of the European Society of Radiology, Your Excellency Dr. Mark Murphy, Physician-in-Chief at the American Institute of Radiological Pathology, Your Excellency Dr. Abdelkarim Al-Zubaydi, President of the Pan-Arab Association of Radiologic Societies, Your Excellency, Presidents of all Arab Radiology Societies, valued professors, doctors, technologists, physicists, and trainees, welcome to Saudi Arabia, to Jeddah, the bride of the Red Sea, and to the 12th RSSA annual meeting. And many thanks to our distinguished speakers and guests for taking the time and effort to participate in this annual meeting. With your support, I'm sure this meeting will be a great success and of great benefit to all. I'm pleased to announce the opening of the 12th Annual Conference of the Radiological Society of Saudi Arabia, featuring a very rich scientific program with a wide range of lectures conducted by more than 60 distinguished speakers from all over the world. As you know, the month of October is the Breast Cancer Awareness Month. We therefore made breast imaging the main theme of this conference and decided to recognize and award the pioneers in breast imaging in the Kingdom of Saudi Arabia who had established the basis for diagnosing breast disease in this country. Our conference also features an exhibition. During the official opening ceremony this afternoon, I will give more details about this year's annual conference. Thank you and best of luck, and all. And now I would like to have the honor of introducing our guest speaker, the President of the European Society of Radiology, Dr. Boris Berkelcic.
Good morning, ladies and gentlemen, dear friends. I would like to thank Dr. Janjum for inviting me here. It is a great honor to be in Saudi Arabia on behalf of European Society of Radiology, and Radiology Society of Saudi Arabia is a very important partner of European Society of Radiology, as are the other Arab radiology societies. So allow me first to present something about European Society of Radiology, to speak about our activities, the advantages of the membership of European Society of Radiology. Then I will speak about European Congress of Radiology, which is our main annual scientific and professional meeting. And I will finally give some information about the involvement of Saudi Arabia in the European Society of Radiology. So, European Society of Radiology currently is the largest radiological professional and scientific society in the world, with more than 121,000 individual members from 182 countries, and societies that are part of our society are primarily 48 European national member societies who are institutional members, then 15 European subspecialty and allied sciences member societies. These are societies like ESGAR, European Society for Gastrointestinal and Abdominal Radiology, European Society for Breast Imaging, European Society for Urogenital Radiology, Interventional Society, CIRSE, and others, including Society of Medical Physicists as well. And then we have 51 associate institutional member societies from all over the world, and many from Arab countries, so that actually now only 1/3 of membership of ESR is in Europe, and almost the same number of members we have in Asia. We have huge membership in Latin America, Central and South America, and also now in the last year, increasing number of members in North America and in Africa, as you can see here. One of important things that ESR, Educational Committee of ESR, produces are so-called training curricula. First for students, medical students, this is curriculum for undergraduate radiological education, and then the most important is curriculum for European training for specialization in radiology, which is quite diverse in Europe. Mostly now residencies last 5 years in majority of European countries. However, there are still some, like former Soviet Union countries, where they are much shorter, and the level of radiology education cannot be compared in these countries to Western European countries. So the problem is that we are trying hard to harmonize education on European level for many decades. And then there is a training curriculum in subspecialty areas as well. One of most important activities of European Society of Radiology is education, and European School of Radiology is our most important instrument in doing this. The other two important tasks are, of course, research and professional issues. But European School of Radiology is now in 13th year of its existence. For 10 years, the scientific director was Nicolas Gourtsoyanis from Greece, who you probably know. Now it is Valérie Villegran from Paris. And European School of Radiology offers many different types of education. It offers scholarships and fellowships of different types, exchange fellowships, short-term fellowships, one-year fellowships, visiting scholarship programs, different seminars, schools, basic, more advanced, so-called visiting professorship programs. There is also now large online courses, possibilities to see many online activities. through the educational platform of European Society of Radiology. Most of these educational materials are actually from European School of Radiology, and they are completely freely accessible to all our members. And there are also ESOR courses for European diploma in radiology, and I will speak about European diploma a little later. So, yeah, basically European diploma is quite successful endeavor that exists since 2011. We had for instance, last year, more than 800 people who undertook this examination. So far now, more than 3,000 radiologists from different parts of the world took this examination, which comprises of three stages. All are computer-based. Initially, when this initiative started, there was oral examination also, but we changed this oral part to so-called clinically oriented reasoning evaluation because we thought that it would be much more homogeneous and fair not to have oral examiners. So you have three parts: multiple response questions, short cases, and then clinically oriented reasoning evaluation. The pass rate of examination is 67%, which means that 2/3 of those who undertake it pass. And it is now in Europe recognized as equivalent of exit training examinations in Netherlands and Poland, and Croatian national board examination, and also first section of Turkish board examination, one part of Finnish and Slovenian national examinations, and some other countries are considering to actually acknowledge it as an alternative to national specialist examinations. European Society of Radiology publishes 3 magazines. Most important is European Radiology, which is the strongest European scientific and professional magazine with impact factor around 4. Then we have Insights into Imaging, which is a magazine that publishes mostly professional papers, guidelines, and is also gaining more and more popularity in radiology community. Editor of European Radiology is Yves Meny from Paris, of Insights into Imaging, Luis Martí Bonmati from Valencia, from Spain. And there is a third magazine, European Radiology Experimental. This is the youngest magazine. Editor is Sardanelli from Milano, and it publishes research, basic research in radiology, and is quite successful and is already cited in Medline. Then there is so-called European Training Assessment Program that used to be based on on-site visits by 3 European experts in different departments to assess the quality of education of residents in different European departments. Now we also converted it to online process, so everything is done online with evaluation of documentation through online application, and then videos and reports by facilities of departments where the education is performed, and online interviews with radiologists offering education, so tutors, but also residents, and then certifications are awarded according to the assessment of these departments. You can find all the details about this on the website of ESR. Then there is Accreditation Council in Imaging. This is also a relatively new initiative that exists for 3 years, which means basically that if you want to prolong your license in Europe, you need to gather a certain number of educational points or credits over the years. And we used to accredit all events in radiology in different European countries, but now through this Accreditation Council in Imaging, it is much faster and much better procedure with very high quality. It is in coordination with so-called UEMS, Union Européenne de Médecins Spécialistes, and basically now most imaging courses are accredited through this, in this way. And it's also recognized in other countries for CME credits. Then we have a large Department of European and International Affairs that tries to influence European politics in Brussels regarding quality and safety and radiation protection, education and training, research and e-health. And European Institute for medical imaging research is very important for research in Europe in radiology. It's run by Kristin from Rotterdam, past president of ESR. It coordinates collaborative European research in biomedical imaging and supports dissemination and community outreach activities. And by now, more than 80 million euros were assigned to different departments for research from European Commission with the help of this ABIR, European Institute for Bioimaging Research. Then there is Eurosafe Imaging campaign, which is very important flagship of our society, and Guy Frija, who is running this initiative, will be here at Congress here in Jeddah, and he will speak more in detail about Eurosafe Imaging. There is also, as you know, Arab Safe Imaging, which is very well developed. Basically, it's initiative to promote quality and safety in medical imaging, and the mission is to support and strengthen medical radiation protection across Europe. There are several calls for actions and initiatives that are being performed through Eurosafe, so Guy Frija will speak more, but one of important things is dissemination of guidelines and implementation policies for clinical decision support system in Europe and elsewhere, and Saudi Arabia was quite engaged in this initiative from the beginning. There are many others that I'm not going to speak now more because Frija will have separate lecture, but this is developing of diagnostic reference levels for children and for adults, among others, and improving information and communication with patients about radiological procedures. And basically, departments can apply for so-called Eurosafe stars, depending on how well radiation protection is implemented in different European departments. ESR iGuide is a very important initiative. This is actually done in cooperation with American College of Radiology. This is clinical decision support for ESR's imaging referral guidelines. We have referral guidelines subcommittee that adopted ACR appropriateness criteria. They were Europeanized, and this is basically evidence-based content that is available for localization and adaptation through clinical decision support, either as ISR iGuide portal, which is accessible for free for all ESR members, or it can be fully integrated into electronic health records. And this is very important because we know that many imaging referrals are really not appropriate. Patients are exposed unnecessarily to radiation, and using this system, we can reduce a certain number of unnecessary examinations. So the elements of good referral are to see if the test has already been done, which can be seen through this system. If the system requires referrers to submit a clear reason for the exam online, which is not often the case in clinical practice. And then the system provides feedback whether imaging is the best answer or whether maybe CT can be replaced by MR or by ultrasound. So it provides feedback on the appropriateness of different modalities for a clinical indication. So this is a combination of guidelines plus decision support that provides best option to improve clinical practice. And this is how it looks. Referrers select test, enter reason for exam, and then they get feedback. For each consultation, system generates unique decision support number, and we can then follow up after a certain period. We had pilot project in 4 hospitals in Croatia. You can record all decision support data. You can provide useful statistics, and basically you can really see which physician is ordering exams appropriately and who is not ordering them appropriately. In Saudi Arabia, there was a pilot project with King Abdulaziz Medical City that was successfully concluded earlier this year. It was seen that there was improvement in imaging appropriateness from approximately 77% to 87% in just 2 months. And the full implementation is expected to start in the last actually now, in the end of 2019. There is also full implementation at one private hospital in Saudi Arabia that should be completed relatively fast. And this ESR iGuide can be implemented with new electronic hospital records or through existing integration with electronic hospitals records, including EPIC and Cerner Millennium that we know also present in Saudi Arabia. So for this very important initiative, you can find more information on website, and also Frija will speak more about importance of appropriateness of imaging in radiation protection. Finally, International Day of Radiology is November 8th, coming very soon. This is the day when Röntgen discovered X-rays. Every year there is some main theme. This year it will be sports imaging. This is worldwide initiative led by ESR, and this day is celebrated in more than 170 countries all over the world. It is important to increase visibility of radiology that is often not so well visible, so you can also download this booklet in sports imaging. There is also a very new initiative. It's called ESR Connect. It exists just a month ago. This is new video platform providing educational and entertaining videos in the field of radiology. There are 3 channels: ESR Connect Live, ESR Connect On Demand, and ESR Connect People, and I kindly ask you to look at it in web. It's really very interesting. The advantages of ESR membership are that there are reduced registration fees for ECR, free electronic access to all magazines, all educational materials, to all activities of European School of Radiology, and also participation in European Diploma in Radiology. Corresponding membership is free, so you can contact your society to become members through Saudi Arabian Radiology Society. So this is different concept to RSNA. Basically, the membership is free, or European radiologists pay only 11 euros of membership. There are some programs that help people from younger people, either radiologists or residents. It's called Invest in Youth, to come to ECR. So ESR offers them free registration and accommodation voucher, but they need to submit abstract for ECR. And also the same program exists for radiographers. It's called Shape Your Skills. European Congress of Radiology is the annual meeting of ESR. Last year we had more than 30,000 participants, 191 from Saudi Arabia, 14,600 were Congress attendees, 8,600 industry representatives, and 7,000 people watched live ECR, 125 from Saudi Arabia. So there is option that members watch online. So I'm very happy that for 2020, because I will be president of Congress, we have now even more increase in number of abstracts. We have now for the first time more than 9,000 abstracts submitted for the Congress. So I hope that Congress will continue to grow. And we have this Meet Countries program for 21. Saudi Arabia will, together with Oman and United Arab Emirates, be one of ESR Meet Countries. So I hope that this will further strengthen our relationship. Saudi Arabia was already member country, and there will be some other European countries and India. Also, there is new initiative for ECR 2020 to plant tree for every participant at ECR. So we expect to plant 30,000 trees in effort to counteract effects of global environmental crisis. Regarding members of ESR members from Saudi Arabia, the numbers are really growing very highly, and this year we have more than almost 2,500 members, which is really great achievement. Regarding abstracts, last year 38 abstracts were submitted for Congress and 26 were accepted. And as I said, we had 191 Saudi radiologists on site and 125 were watching online. I hope that also many Saudi radiologists submitted abstracts this year. I'm very happy that Egypt is number 10 among all countries per number of abstracts submitted. So we have really many participants from Arab countries. This is the timeline. The deadline for abstracts submission for 2020 has already passed, but until November 30, there is this membership final application deadline, and you can still, until December, submit case-based diagnosis training abstracts, and also if you have clinical trials, they can be submitted until November 14. So I really hope to see many Saudi radiologists in Vienna, and thank you once again for invitation and opportunity to speak about ESR.
So thank you very much, Professor Berkelcis, for this great presentation. And our next speaker will be Dr. Imad Najib, who is the General Manager and Board Member at Al Salam Hospital at Al Muhandisin. He's the Head of Radiology Department at Al Salam Hospital, and he's an ex-com board member at the International Society of Radiology since 2018. He's also a board member at the Chamber of Private Healthcare Providers since 2006. Dr. Najib is a board member of the Medical Export Council since 2014. He's also the Assistant Secretary General of the Pan-Arab Association of Radiological Societies since 2017. He's the advisory board member of the Egyptian Society of Radiology and Nuclear Medicine. So Dr. Najib is going to give us an introduction about the Egyptian Society of Radiology and Nuclear Medicine.
Good morning. I'm very happy to be here in Saudi Arabia. Thank you very much, Dr. Lamia, for inviting us, and I hope, and I'm sure that it will be a very fruitful meeting for everybody. I'll give you a brief introduction about the Egyptian Society of Radiology and Nuclear Medicine. It's interesting and surprising to know that the different diagnostic methods recently used by the medical professions are not so far away from those used by ancient Egyptian doctors centuries ago. The Egyptian Society dates back to 1958 and was established in the early 1960s as a society of radiodiagnosis, radiation therapy, chemotherapy, as well as nuclear medicine. It is the oldest radiological society in the Middle East and Africa. In 1989, it became a member of the ISR, the International Society of Radiology, and in 1993, radiotherapy and chemotherapy separated to form a new society for their own. In 2006, we had the 13th European Conference on Neurogenital Radiology, the Azure 06, and it was in Egypt. And Dr. Tariq Dayasti, the president of Egyptian Society, was the chair of that meeting at that time. In 2007, it became a founding member of the Pan-Arab Association of Radiological Societies, the PARS. And in 2009, we had the opportunity to host the second Pan-Arab Congress of Radiology, ARC10, in Alexandria at the Bibliotheca Alexandrina, which is considered as one of the most successful meetings with more than 2,000 participants and 43 international speakers. Again, in 2007, with collaboration with the Ministry of Health, we organized the breast cancer screening in Egypt with 6 mobile trucks dedicated to free mammography exams for a national campaign launched for the early detection of breast cancer. It was an excellent campaign covering 6 governorates, Cairo, Alexandria, Suez, Ismailia, Fayoum, and Asyut, and resulted in detecting 94,274 cases. I think these cases had their lives saved by this campaign. The number of active registered radiologists in Egypt is 4,800, although we think that it's more than 8,000, the real number, but most of them are not registered. And the members of the society are more than 2,600. In 2010, again, the Egyptian Society became a member of the Pan-African Radiology, which is the society of the Pan-African Society of Radiology, and it hosted the second meeting of the society from April 3rd to 6th, 2012, and it was again in the Alexandria Library. In March 2012, we had a session of ESR Meets Egypt during the European Congress of Radiology, and gave us a huge opportunity to show a taste of Egyptian radiology and culture. From 2012, the Egyptian Society started to organize 2 radiology conferences per year, one in April, the other in October. This is the banner for the second African Society meeting in Egypt, ASR 2012. And this is a photo with some of our dear friends that you can recognize some. Again, this is a photo from Vienna. Actually, it was the last day of the conference, and we were just tired, and we took that photo in the booth with no one in the whole Vienna Center. This is again a photo in Vienna during the Voice of Epos, the Egyptian session, and it's growing very much, and we thank the European Society for giving us this opportunity of having our own sessions in the European Society meeting. Again, it's a photo with Dr. Tarek Dayasti and the Egyptian ambassador, and behind us the skull and flowers of our dear friend Dr. Paul Parizel, if you remember this particular meeting. And in the UN, we were invited to attend a session in the United Nations for radiation protection and radiation safety. The 28th International Congress for Radiology, the ICR, was supposed to be held in Egypt, but due to turbulent circumstances at that time in Egypt, we had to move it to Dubai. We had a huge meeting with 11 parallel sessions, and it was attended by many, more than 1,000 attendees. Again, we had the 16th Mediterranean African Society of Ultrasonography, the MASU in Alexandria, and the 10th Arab Radiology Conference was in Alexandria in 2018. This is a photograph that I really like. It was posted by our dear friend Eric Stern on his Facebook account, and he said that this is a photo with some of my dearest friends of radiologists. This was during the ICR in Dubai, and you can see many of the very esteemed radiologists from all over the world in this photo. This is the banner for the ARC 10 and the 52nd Egyptian Conference in 2018. And this was the 5th African Society meeting in collaboration with our meeting. It was held in Cairo from January 16 to 19 this year. It was a very successful meeting as well, with hundreds, maybe we had around 50-something international speakers. And this is a photo from the meeting, and I think you can see some of our very dear friends from here and from everywhere. Each year, RSNA invites the National Society of a chosen country to present a session at the RSNA to educate RSNA attendees about the latest science and education activities and cultures around the world. This year, 2019, we are honored to have our session, Egypt Presents, during RSNA in Chicago. It will be on December 3rd. And please, if anyone is attending the RSNA, we'd love to see you there. And this is the session. This is as posted on the RSNA website, Egypt Presents. Our next meeting is in a few days. It will be in the beautiful coastal city of Port Said in Egypt, and we're having some of our very dear friends, as you can see some of the photos here. And again, more of our Arab radiologists. Our future meetings will be the 57th conference. It will be in Cairo. It will be in collaboration with North Africa Health from April 7th to 9th. Then the PARS meeting in Beirut. It will be the new date for it. It's from April 22nd to 25th. And of course, there is the ICR meeting that will be held in Oman, October 1st to 4th. And I hope that we'll see quite participation from the Saudi doctors with us in the PARS and in the ICR. One of the activities of the Egyptian Society is the Egyptian Journal of Radiology and Nuclear Medicine. It was established as a peer-reviewed journal in 1986. It publishes 4 issues per year, and from 2010 it was published by Elsevier, but right now we moved to Springer. The Egyptian School of Radiology, we have our School of Radiology, which is, well, we started the idea with our friends from the European Society. I remember we sat with our Dr. Nicholas Gortsouyanis in Alexandria a long time ago, and we discussed making an Egyptian School of Radiology as part of the European school. But we decided that we'll go our way, and we organized our own, and it's a very successful school right now. A lot of people benefit from it. Again, we hold the examination of the European Diploma in Radiology in Egypt, and we will, I think it will be held during our conference in April, but the next one will be in Vienna 2020. This is the exam, and there is still a limited number of places available for whoever wants to participate in it in Egypt. It will be on April 4th. Remember the PARS meeting, but the new dates are changed from 22nd to 25th April, so that not to compromise any attendance from our Tunisian friends. And this is a photo from the ISR. The ISR EXCOM meeting during ACR 2019, we were there. And we're proud that two Egyptians are in the executive committee of that society, Dr. Tariq Dasti and myself. And of course, we'd like to see more of the Arab radiologists participating and entering into the ISR EXCOM in the future. We're very proud that our president of the society, Dr. Dasti, he received an ESR honorary membership in 2013 in Vienna. And this is the photo of Tariq in Vienna receiving the trophy. Again, the British Society of Emergency Radiology gave Tariq an honorary membership early this year. And during the RSNA this year, Tariq is receiving again an honorary membership with, I think, the highest decoration any radiologist can get outside of this. These are a few photos from my country, Egypt. I'd like to see you come for a vacation. This is Upper Egypt. And also we have Aswan and some beautiful beaches. Thank you, and please visit our website. Thank you very much.
Good morning, everybody. It is with great privilege that I introduce our next speaker, Dr. Boris Brkljačić. I hope I'm pronouncing that correctly. Okay, good. Dr. Brkljačić is the Vice Dean for Science and Chair of Radiology Cathedra at the University of Zagreb School of Medicine in Zagreb, Croatia. He is the chairman of the Department of Diagnostic and Interventional Radiology at University Hospital Dubrava, Zagreb, Croatia. He joined the ESR in 2011, where he held multiple positions, including his current being the president of the ESR, He is the president of the upcoming European Congress of Radiology 2020, ECR 2020. Since 2005, he has been the head of the Radiology Advisory Board of the Ministry of Health for National Breast Cancer Screening Program in Croatia. He has written 2 monographic textbooks, 60 chapters in textbooks, and over 110 papers in peer-reviewed journals. His fields of interest include both interventional radiology and breast imaging. He will be presenting 2 talks for us this morning. The first is titled Imaging Features of Different Breast Cancers, and the second is Updates in Breast Ultrasound. Without further ado, please help me in introducing our first speaker of the session, Dr. Brkljačić, to the stage. Thank you.
Thank you very much. Again, you pronounce my name much better than Americans and most Europeans. So as Lena said, I'm going to speak today about 2 related talks. One is imaging features of different breast cancers, and then I will speak more about ultrasound, so some of these things will be repeated. Now, we know that the management of breast cancer is changing considerably. We know that not all breast cancers are the same. There is tendency now to do less surgery and to have more smarter targeted therapy. It is much more common now to perform chemotherapy before surgery, so-called neoadjuvant chemotherapy, especially for some types of cancers that react well on neoadjuvant chemotherapy. Also, it was shown that it may not be necessary to completely remove all cancer from breast or lymph nodes by surgery. And the role of imaging in this context is increasing because we need to know exactly the tumor size, the distribution of lesion, the extent of the disease, and also intra- and intertumoral heterogeneity. All these are essential features for proper diagnostic characterization of breast cancer and also for proper therapy selection. And we have our 3 modalities on disposal: mammography, ultrasound, and MR of the breast, that we need to use in many cases together and know what are the features of different breast cancers in these different modalities. And it is standard now to perform biopsies. This is needle under ultrasound guidance that is very easily and very precisely taken to the edge of the tumor, and then we fire the needle through the lesion. This is very small tumor of only 6 millimeters, but we can get pre-therapy exact data about the type of the tumor, about the histologic grade, about the status of receptors, HER2 status, and proliferation index Ki67. This is all very easy to obtain by analyzing on histopathology specimen that we obtain with core biopsy. And we know that there are 4 basic types of breast cancer by gene expression profiling. Most common are luminal A and luminal B cancers that are estrogen and progesterone receptor positive, but luminal B have higher proliferation index. And then luminal B cancers can be either HER negative or HER positive, or we can have only HER positive cancers that are estrogen and progesterone receptors negative, that are much more biologically aggressive. Some 15% of tumors are HER positive. And then we have triple negative or basal-like cancers, another 15% that are quite aggressive. There are many subtypes, but these are 4 basic types. And luminal, so HER positive tumors and triple negative tumors have highest local regional recurrence. We need to be aware of that when we think about therapy, which is different. So HER positive and triple negative cancers have the highest recurrence rates compared to luminal A and luminal B tumors. Now, regarding imaging, usually I will speak more about ultrasound in next lecture, but just a simple assessment of vascularization on color Doppler is very good to give you a general overview of whether tumor is highly vascular or not. Many breast cancers are serous and do not show internal vascularization, but nevertheless, if you have highly vascular tumor, this is usually a marker of a larger aggressivity, and it is very easy to do it with ultrasound. Also, now we have elastography, where we can look at the stiffness of the lesions. With two types of elastography. In strain elastography, usually rigid tissues are blue and soft tissues are bright. And then, for instance, we can, by combining B-mode morphology of lesion and its elastographic appearance, and usually lesions which are hard are larger on size on elastogram compared to B-mode, quite clearly deduce that this is malignant tumor and then that these stiff lesions should be biopsied. Unlike this example, quite large lesion on B mode, which is completely soft on elastography, which is typical for fibroadenomas. So these are already some imaging features that are very useful in planning of biopsy. Or there is another type of elastography, shear wave elastography, where stiffness can be quantified. Colors are different here and stiff lesions are bright. I will speak more about this in another lecture, but we can here quantify and measure stiffness of lesions. And again, there is difference in different type of cancers if we look at these quantifiable numerical parameters. So invasive ductal cancers, usually on shear wave elastography, are very reddish and have high values of so-called, in kilopascals, of so-called Young's modulus of elasticity. We usually measure this Emax or median levels. And this is very simple way where ultrasound uses the fact that acoustic impedance depends on elasticity of lesions and density of lesions. So it took maybe 30 years or 40 years of use of ultrasound in clinical practice to be able to quantify stiffness, which is one, or elasticity, which is one of the inherent physical features of ultrasound imaging. Many cancers may not be uniformly stiff, but have this halo of peritumoral stromal stiffness that we see, so-called blue cancers with a ring of high shear wave speed around the tumor. When you see this finding, it's very clear that this is malignant tumor. But the other thing that we have to look at is really the shape of tumor. Now, and of course, also there is this color assessment of maximum elasticity in elastography, where in shear wave elastography, harder lesions are reddish, and we can measure it in kilopascals. Some machines measure in meters per second, but standard now is to measure in kilopascals stiffness of lesions. The other thing that we look at imaging both in mammography and ultrasound and in MRI, and we see here post-contrast T1 subtracted sequences after early after injection of contrast medium. We see that this highly enhancing lesion is spiculated, so that it has very irregular margins. And usually in textbooks and also in mammographic textbooks, we are looking for lesions that have irregular borders and spiculations, because this is a feature of invasive cancers that grow into surrounding tissues like this sun rays in infiltrative pattern. But we also always have to remember that most of these spiculated cancers are actually luminal A and luminal B cancers. Morphology of breast is best identified in early post-contrast subtraction images on MRI, and this is also the basis of currently advertised abbreviated MRI screening protocol, which might be very useful, especially in women with high risk for breast cancer, where you really don't need to do full protocol with 5 post-contrast sequences, but only do 1, where you can really get very well, where you can really see very well these abnormally enhancing lesions. But again, we see here irregular borders that speak in favor of cancer. Now we know that the problem in mammography are dense breasts. So this is very relatively common example of dense breasts. According to literature, some 40% of women have density over 50%, meaning that the volume of breast that glandular parenchyma composes is higher than 50%. And the problem in mammography is that there is overlap of fibrostructures in glandular parenchyma and stroma with cancer. So you may not see even large cancers in very dense breasts. And in addition, density carries higher risk of malignancy by itself. So women who have dense breasts have higher likelihood to get cancer. And the problem in mammography, also in screening, is that we don't see these lesions well. So we have to combine, and now in many European countries, including in mine, all women in screening who have breast density over 50% are offered additional ultrasound. And then in ultrasound, in these large, dense breasts, you can see tumors that are often hypoechoic, and in this case very stiff in this surrounded by hyperechoic glandular parenchyma. But in addition to this irregular morphology, we should be very careful about circular masses in breast. So traditionally it's said that benign features of lesions are those that have regular margins and that are actually circular. But this is unfortunately not always the case. The problem is that most malignant breast cancers, like triple-negative cancers, typically have circular shape. And you can, if you are not very careful, you should not really say that something which is circular is benign. For instance, medullary cancers, and many medullary cancers are also triple-negative, have this typical feature on both ultrasound and MRI of relatively well marginated circular lesions, and they are not as stiff on shear wave sonoelastography as other non-invasive, as other non-triple negative invasive ductal cancers. So when we see lesion like this doesn't mean that it is benign. We should look very carefully for slight irregularities. This is same patient on ultrasound, on mammography, and on MRI. On MRI, we see clearly this one irregular ductal extension of this tumor, but we should be very careful not to say that something that looks circular on a first glance is really benign tumor, because it might be exactly the opposite. It may be the most aggressive tumor. And very important work on this was done by Tibor Todt, who probably many of you who are breast radiologists and who come for European Society of Breast Imaging meetings or ECR know. Tibor Todt is pathologist in Sweden, originally from former Yugoslavia, from North Serbia, Hungarian, but he left in '91 to Sweden, and he published probably the best papers in last 30 years on breast imaging. He was working along with Laszlo Tabar, and we are very lucky that he comes very often to teach in our country, and he was basically, I would say, the teacher to all our pathologists. And if you look at these large series that they collected, if you look at the proportion of circular lesions by histologic tumor type, in so more than 1,300 invasive cancers in single institution in Sweden, we actually see that higher grade of invasive ductal cancer. So look here, grade 3 has much more often circular shape than invasive ductal cancers of lower histopathologic grade. And histopathologic grade by Elston, Brom, Richardson is very important prognostic factor of aggressivity and invasiveness of breast cancer. And also mucinous and medullary cancers are almost always circular. So we need to remember this. So when we look at the proportion of invasive breast cancers by radiological shape and histology grade, circular tumors are much more commonly grade 2 and grade 3, while stellate cancers are quite rarely grade 3 on histopathology. So correlation of radiological morphology and pathology is extremely important, and we should bear in mind that, of course, we look for stellate cancers. They are much more common. More than 70% of cancers are stellate, but really aggressive cancers can be circular, and we need to know this. So, for instance, this is 24 years old girl. She was daughter of my friends, and you always think that in this age there is only fibroadenoma that you can find. But if you look carefully, this lesion, which is horizontally located, so this is not Bayrad's really typical criterion for malignant tumor. I will speak about this in second lecture. It's horizontal, it looks quite regular, but there is this one single ductal extension here. When you turn on elastography, it is extremely stiff. So fibroadenomas never look like this. This was unfortunately very invasive, grade 3 HER-positive cancer in very young woman. So basically in this age, unfortunately, the prognosis is really not good in spite of all modern chemotherapy treatment. So once again, if we look at immunohistochemical parameters, and this is now really, I would say, everyday practice since last maybe 5 years, everybody is determining in histopathologic specimen estrogen receptors, progesterone receptors, and HER2 status. Again, if we look at circular lesions on morphology, on any imaging modality, compared to stellate spiculated lesions that are most common, circular lesions are much more commonly estrogen receptor negative, triple negative, or basal-likes, which means that they are much more commonly biologically aggressive. Also, if we look, for instance, at elastographic features of different breast cancers, there were many publications where we were looking grade 1, grade 2, and grade 3 cancers. Grade 3 cancers are also stiffer, so more aggressive cancers are stiffer. We can assess all this by imaging, and according to immunohistochemical properties, whether these are estrogen positive, HER positive, or triple negative cancers, again, more aggressive cancers are stiffer, as we see here. So if we correlate stiffness and histologic grade, soft cancers are more likely to be low grade, tubular and mammography screen detected. Cancers with high histologic grade, large cancers with lymph node involvement and vascular invasion were associated with higher elasticity parameters, meaning higher mean or maximum stiffness values that are expressed in kilopascals. And large variation in stiffness was also found with different size cancers. So it's not the same if you look at very small cancers or cancers that are larger than 2 centimeters. This indicates that intrinsic tumor biologic factors are causing variation in tumoral and peritumoral stiffness. For instance, we looked at triple negative cancers that are, as we said, much more commonly circular. And we have seen that if we compare triple negative cancers to other non-triple negative invasive ductal cancers, of course, triple negative cancers are more often regularly shaped, and they are less stiff, especially less stiff in internal part than other than other invasive ductal cancers. So their elasticity is statistically significantly lower, but they are still stiff, and we need to be especially careful not to miss these highly invasive cancers because of their so-called benign morphology on the first glance. And another data from TOT, where you compare molecular features of early versus more advanced breast cancers depending on size and also status of hormonal receptors, we see that that advanced breast cancers are much more commonly ER negative and triple negative and HER positive and have higher histological grade, grade 3. So this is very important to know. Also, MRI phenotype is very important predictive biomarker for tumor response after neoadjuvant chemotherapy. Now we know that neoadjuvant chemotherapy is now more and more being given before surgery to women with newly diagnosed breast cancer. And we know that complete response, so disappearance of tumor on follow-up MRI, is strong predictor for long-term disease-free survival and overall survival in breast cancer. So up to 30% of patients can have this complete response, some 55 partial response, and there are some patients that have really no response. If we look which patients have best response, we should look at circumscribed masses as opposed to lesions with patchy enhancement and nodular diffuse infiltration. Basically, MRI best predicts response in most aggressive cancers, which are triple negative and HER positive breast cancer. So when you have this circumscribed large mass and you do biopsy and you see that it's either triple negative or less commonly HER positive, we now immediately do neoadjuvant chemotherapy to these patients. They don't undergo surgery. Even if tumor is possible to be resected from the surgical standpoint, so it means that these are not tumors that infiltrate areola or pectoral muscle, but still, and if you look at here, the patient, this is the same patient with very good ultrasound and MRI phenotype for complete response on neoadjuvant chemotherapy. These three images here are before, and these three on the right are after neoadjuvant chemotherapy. So this was large enhancing tumor. This is diffusion-weighted imaging where we see restriction of diffusion, which is really considerable. And this is ultrasound image of circular lesion, which is stiff only at the edge. After 6 cycles of neoadjuvant chemotherapy, there is no enhancement anymore on MRI. There is nothing on diffusion-weighted imaging, and also appearance on ultrasound, we see that mass is much lower and it is completely elastic. So this is very good. In addition, now we use contrast-enhanced ultrasound. Also, I will speak more about it in a last lecture. So this was triple-negative breast cancer, which has really very good reaction after neoadjuvant chemotherapy. Another example is this large HER-positive luminal B cancer, sorry. So this is large cancer, pre-therapy on ultrasound and on MRI. After neoadjuvant chemotherapy, you don't see it here. This was enhancement, but fat was, we didn't do fat suppression here deliberately, and this is post complete response where you see that lesion is almost not visible on B mode and it's completely elastic. As opposed to this example, this is a large cancer, enhancing cancer before therapy and after therapy. So this is before and after therapy. Unfortunately, it's completely the same. So there is large enhancing mass, and which is still stiff on ultrasound. The other thing that we need to remember, so breast cancer is not always unilateral and unicentric cancers. So multicentric and multifocal disease is much more common than we think. Actually, more than 60% of cancers are multicentric or multifocal, either have foci within 2 centimeters of index tumor or more than 2 centimeters. And of course, MRI is the best modality to look at it. So on mammography, you may see, like in patient like this is 20 years ago, this woman had this multicentric cancer. You would say that this is bad prognosis, but she is alive for 20 years. She was 52 then, she is now 72, completely well. So sometimes good oncologic therapy is really excellent. But of course, MRI is by far the best imaging modality to look at multicentricity and like in this case of multicentricity and bilaterality of breast cancer, which has clear histopathologic correlate in these 3 invasive foci in different parts of breast. And just to so when we look at this lobar anatomy of breast that Toth and Tubul always proposed, there are 15 to 20 lobes of breast that are circularly in space arranged around areola. And ultrasound is the only imaging modality where you can really follow lobe very well. On MRI, this is same patient. There is just superposition in 3D of all enhancing lesions. But in ultrasound, we can put the transducer longitudinally to the lobe, and we see 3 different invasive cancers that are, as you see here, 1.6 or 1.2 centimeters apart from each other. So ultrasound is the best modality to assess lobar extent and lobar spread of cancer. So multicentric cancers are, of course, important. And finally, we should not forget about DCIS, ductal cancer in situ. They also have 3 different grades, low, intermediate, and high, depending on histopathologic parameters, polymorphism of nuclei, and presence of central necrosis. We need to know this. Also, we know that microcalcifications are most important radiological sign on mammography of ductal cancer in situ. Grade 3 cancers have microcalcifications in much higher proportion than lower grade tumors. And when we speak about over-treatment and over-diagnosis in DCIS, in screening, this relates to low-grade in situ cancers, but high-grade in situ cancers will almost certainly progress into invasive cancer, and they have to be treated well. So if we see this cluster of abnormal calcifications, of course we do normally mammographic guided biopsies, but in most patients you do find ultrasound correlate, like in this case, where there is clear correlate to microcalcifications, and they are even stiff. So basically, or here you see this cluster, that this is just cluster of DCIS without associated microinvasive component. We even see increased vascularity. So combination of different imaging modalities is very important here. And in this huge breast, this woman had nothing palpable. Half of the breast was in cancer. This was ductal cancer in situ. You can see well also on ultrasound these small hyperechoic dots that are actually reflecting these clearly malignant microcalcifications. And so correlate in different imaging modalities is quite clear. She was totally asymptomatic. Or, for instance, this case, she was breastfeeding, had baby 1 year ago. She had this huge non-mass enhancement in the left breast, which was hypervascular on color Doppler. You see changed area on B mode and increased stiffness. This was a rare case of hypersecretory ductal cancer in situ. So we need to think that also ductal cancers in situ that are seen on microcalcifications often do have, especially if they are higher grade ultrasound correlate and increased stiffness and MRI correlate. This is same patient, non-mass enhancement in addition to the large cyst with washout type of curves. So we should combine all these three imaging methods, and when we see finding like this has to be biopsied. This is not some unimportant DCIS, and this is very good example of women who, so this was non-mass enhancement here. She was referred to biopsy. She refused suggested biopsy. After 6 months, there is huge progression, and finally when she, and first there was persistent curve here, there is now washout type of curve here, and when finally she accepted to do biopsy, it was DCIS of high grade with multiple small microinvasive IDC foci, so we should not just overlook DCIS as something non-important and overdiagnosis unless it is really grade 1. So correlation of imaging modalities with histopathology is extremely important. Once again, ultrasound with increased elasticity and non-mass enhancement in another case of ductal cancer in situ. And when we compare, there are 2 papers. One is actually ours from the last year. MRI and ultrasound for BIRADS 4 and 5 microcalcifications, actually sensitivity, specificity, positive predictive value and negative predictive value of MRI is quite high. Of ultrasound is also not bad. It's better with MRI, and there is rationale to perform MRI if you can afford it and have it on disposal to patients with malignant or suspicious microcalcifications, because you see much easier the extent of tumor and of non-mass enhancement if it is present. And again, regarding distribution of in situ component and its grade, grade 3 invasive ductal cancers are much more commonly diffuse. So we should not forget ductal cancers in situ. There is often invasive tumor which is hypervascularized with large DCIS component. So this tumor apparently developed from DCIS that was not diagnosed on time. So to conclude, tumor size, lesion distribution, disease extent, intra and intertumoral heterogeneity are essential for proper diagnostic characterization of breast cancer. Image-guided biopsy is crucial in selection of the type of breast cancer treatment, and imaging features of in situ and invasive cancers need to be taken into account at multidisciplinary team meetings to select the type of treatment and also to follow up treatment, especially now in the era of neoadjuvant chemotherapy. So thank you. This was the first lecture. And now I can immediately continue with another one, which is number 4. Can you maybe tell them to give another, to put on another lecture? He doesn't listen to me. Can I have another lecture? Number 4. Yeah, and so in the next lecture, I will speak I will focus more on ultrasound. That is often neglected modality among radiologists. We know that, of course, mammography is the most important imaging modality that we have on our disposal. But we know that, as I said, the density is problem with mammography. The higher the density of mammography, the lower is the sensitivity to detect cancer, and then addition of ultrasound enables us to see many more cancers, and now many screening programs in Europe offer additional ultrasound to mammography. So what is really ultrasound? When we speak about multiparametric ultrasound, which is a very popular term in last few years, this just means combination of B mode or grayscale ultrasound feature plus color Doppler vascularization of lesion plus elastography assessment of stiffness of lesion, and they are now also part of BIRADS descriptors for ultrasound, color Doppler and elastography. And then in addition to this, we can have contrast enhanced ultrasound also. So these are multiparametric. Now, You should always use the best transducer with highest frequency and use advanced software like compound imaging and harmonic imaging to do ultrasound exam. Compound is electronic beam steering, where multiple images are obtained from different angles. And harmonic imaging eliminates internal echoes in fluid and improves internal lateral resolution. So for instance, this is same tumor in conventional B mode, and with addition of compound imaging, we see much better internal architecture of lesion and borders in this invasive cancer. Then, as I said, color Doppler is very useful to evaluate vascular pattern of lesions. It's also useful to see with twinkling artifact biopsy marker or clip that we put before neoadjuvant chemotherapy. I will show you some examples later. This is for instance, this is cystic solid lesion. This is male breast cancer, very rare case, but you would say on just B mode that this is some solid cystic lesion. If you just put on simple color Doppler, you see well that this solid part of the tumor is well vascularized, so it's definitely not some complicated cyst. It's well vascularized solid lesion. And finally, as I said, elastography can demonstrate and quantify stiffness by measuring Young modulus elasticity in kilopascals. Then 3D ultrasound is now available both on handheld and automated high-resolution linear 3D transducers, and just with a single pass of the ultrasound beam, you get 3D reconstructed image formed in coronal, sagittal, and transverse planes. Also, there are fusion applications. There are problems when you image woman on MRI. She is lying prone with breasts in coils, and then when you do ultrasound, she is lying on her back or supine, and sometimes position of the small lesion that you see on MRI cannot be easily determined on ultrasound. Then these fusion applications already now exist on some high-end scanners, but we had quite cumbersome problems because it takes long time and it's really not feasible in everyday practice. It's not easy to use it. We should always perform a radial technique and combinations and take care to examine whole breast by ultrasound. If you miss the lesion, then you will not, if you don't show the lesion with ultrasound, then it's impossible to biopsy it. So you have to examine breast very carefully, use B mode, color Doppler, all the advanced software, and look at shape of the lesion, relation of antero-posterior to lateral diameter. This is very important. Whether the lesion is vertically or horizontally located, you should look at margins, internal structure, whether there is absorption of sound, if there is distal acoustic enhancement or shadowing, and then you add elastography now. So in Bayrad's imaging lexicon, ultrasound is very well represented now, in addition to tissue composition, masses, and calcifications that exist now for many years. In the latest edition, there are also so-called associated features and special cases. And under associated features, you have, in addition to architectural distortion, duct changes, skin changes, and edema, also vascularity and elasticity. So you should assess by ultrasound whether there is absent vascularization, whether there are internal vessels or vessels in the rim, and you should also assess whether the lesion is soft, intermediate, or hard, regardless of whether you do it with strain or shear wave elastography. But we should always take into account that Bayrad's 4 and 5 criteria are mostly based on B mode or grayscale. So hypoechoic spiculated lesions with thick echogenic halo, microlobulated, taller than wide or vertically located, that demonstrate shadowing, calcifications, or duct extension. All these are B mode or grayscale parameters. So these are typical invasive cancers, vertically located, irregular, so mostly luminal A and B tumors look like this with shadows. These are clearly Bayrad's 5 features, but if you have horizontal lesion but with ductal extension, irregular with internal calcifications, these are also BIRATS 5, it is enough to have one of these features, and we can look at color Doppler whether there is penetrating vessels. Like in this case, you cannot count on spectra because cancers are stiff and you don't expect to have low resistance spectra in stiff cancers. And this is an example of metastatic axillary lymph node, which was hypervascularized, so we should also look with ultrasound lymph nodes. And as I said in the last lecture, ultrasound is the best modality, much better than mammography or MRI, to look at the lobar extent and spread of cancer within a single lobe. And by theory of sick lobe, this is what is happening. Now, ultrasound is also excellent for doing biopsy using 14-gauge needle. We can easily perform core biopsy, pass through the lesion, and obtain histopathologic specimen to get all the necessary immunohistochemic data. And we have special ultrasound-dedicated vacuum-assisted probes, so we don't need only to do mammo-guided vacuum-assisted biopsies. They can be done under ultrasound. We used 11-gauge vacuum needles where you have just one insertion of the probe and you can retrieve 15 to 20 specimen, but basically we do it very rarely because our pathologists are very good with 14-gauge needle core biopsy. This is much more expensive, but you get much bigger specimen. So basically now we mostly do vacuum-assisted biopsy only for microcalcifications under mammographic guidance. And we can position easily wire under ultrasound guidance or other means of localization of impalpable tumors before surgery so that surgeons remove them, or we can position clip into the lesion before neoadjuvant chemotherapy. There is another thing very briefly. This is radiofrequency ablation of breast cancers that can be performed under ultrasound guidance, under local anesthesia, in patients with small invasive ductal cancers who refuse surgery or in whom generally anesthesia is risky. The advantage is that you do it under local anesthesia and woman is speaking with you during the procedure, so you are not in danger that it will be pain that is unbearable. Normally, liver ablations are done in general anesthesia. Just you need to position very carefully the needle or electrode in the center of the tumor, because once when you start doing ablation, everything is bright. This is after RFA. And then the question of microcalcifications, I have already shown you that there are many, that there is ultrasound correlate in most lesions with malignant microcalcifications. Very clearly we see when we have these malignant microcalcifications, we do see well ultrasound correlate with these bright dots, and they are stiff in addition to this cyst as we see here, and we see non-mass enhancement. So there are, and also for lymph nodes, we should always look at whether there is missing echogenic hilus or lower echogenicity of cortex. We should not rely on maximum diameter as important criterion. And about sonoelastography, I already spoke. There are two types, strain and shear wave elastography. The rationale is that breast cancer is stiff and benign masses are soft, elastic, and mobile. And you can either do with strain elastography, just semi-quantitative or qualitative imaging, and lesions that are hard are dark. With shear wave, it is opposite. Lesions that are hard are bright or reddish. And this is the principle of low or high strain in strain elastography, whether lesions are hard or easy to deform. Of course, cancers are hard to deform and benign lesions are easy to deform. There is this 5-point visual Tsukuba score where benign lesions are soft and malignant lesions are hard, even larger than B mode. And this is example of benign fibroadenoma on strain elastography. This is an example of complicated cyst with so-called bullseye artifact. This is an example of hard lesion of cancer on strain elastography. And opposite to this, shear wave elastography enables measurement, quantification. It's much more reproducible and doesn't require that you press the lesion. Just malignant lesions are reddish or greenish, and we can measure these values in kilopascals, so we can differentiate soft, intermediate, and hard elasticity based on numbers. This is an example of benign lesions of fibroadenomas that are soft. This is an example of DCIS, of invasive ductal cancer that is reddish and very stiff. And as I already said, there is halo of peritumoral stromal stiffness. There is also three-dimensional shear wave elastography. It's very fancy, but I don't think that it really brings much advantages. Now, addition of maximum elasticity value to BIRAT score reduces rate of negative biopsies because it increases specificity of ultrasound by 8% and increases positive predictive value by more than 5%. And as I said already, tumors that have high histologic grade have higher mean stiffness value, and also tumors with higher size are stiffer. So if there are both shear and strain and shear wave elastography, if they are suggestive of benign lesion, confidence is high that lesion is benign, but there are some false negative cases like lymphoma and some false positive that are stiff like mastitis, fat necrosis, and few fibroadenomas. We are now at the end of the lecture, but just to show you, this is large malignant tumor that is soft. This is breast implant-associated anaplastic large cell lymphoma, hypervascular and soft, which is totally unlikely for any other tumor. This is another very rare case that we had, metastasis of plasmacytoma in breast, hypervascular, hypoechoic, and soft. Then it is very popular now to do automated whole breast ultrasound. Just 1 minute on it. Basically, radiographers do examination. You look at images at workstations with these reverse curve ultra broadband transducers. They give this kind of images, and they are advertised for screening, especially in America. We don't I somehow think that it's better to do handheld ultrasound yourself. It's very cumbersome and you have to rescan patients here, but there was a sound study that showed that with this automated whole breast ultrasound, you find more cancers than with digital breast tomosynthesis, in addition to normal digital mammography. So it is advertised for screening. The problem is that peripheral areas of breast parenchyma are not fully covered with ABUS, especially in large breasts. If you have any post-operative breasts, open cutaneous damage, you cannot see it. There is shadowing artifacts. And this means that you have to redo patients with handheld ultrasound. And finally, we can do contrast-enhanced ultrasound. It is supposed to play now, but it doesn't. Basically, there is, in those patients who undergo neoadjuvant chemotherapy, we can look at different types of enhancement, time to peak and maximum intensity. And basically, in neoadjuvant chemotherapy, we see lower, after complete response, there is less vascularization and prolongation of this time to peak after we inject contrast, so it's mostly done for research. So to finalize, ultrasound is complementary to mammography and MRI. It should be initial imaging method in young women. It has higher accuracy for mammographically dense breasts. We can perform biopsies in all visible lesions under guidance of ultrasound. Using advanced software and high-frequency transducers, we can see even most cancers with microcalcifications. Sonoelastography is already established. Automated breast ultrasound increases utilization of ultrasound in screening, and contrast-enhanced ultrasound is done mostly in research. Thank you very much for your
Thank you very much for the brilliant presentation. My name is Dorothy Makinjola, Can I ask you, do you know of any studies taking place in radiogenomics with ultrasound? Because we know that MRI is already doing it to identify the biological subset of the tumor.
Yeah, radiogenomic studies are done mostly with MRI. I'm not aware of really some larger study in ultrasound. We will try now to do something with one Austrian company regarding elastographic features, but in combination with MRI.
MRI. Thank you very much.
Any other questions?
Good morning, everybody. I would like to present the next speaker, Prof. Asma Dabba from King Abdulaziz University Hospital. She completed the Bachelor of Science, Bachelor of Medicine and Surgery, Diploma of Medical Radiodiagnosis, and the Fellowship of the Royal College of Radiologists. She's a member at the Institute of Radiology, Royal College of Radiologists, the British Medical Council, the RSNA, RSSA, European Society of Breast Imaging, and the European Association of Radiology. She was an ex-head of diagnostic imaging at the King Abdulaziz University Hospital and ex-vice dean of Faculty of Medicine at King Abdulaziz University Hospital. Please welcome Prof. Asma Dabba.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to talk about the post-surgical breast, as it is quite complicated, particularly with the new techniques of surgery. Surgical breast interventions such as lumpectomies, quadrantectomies, reduction mammoplasties, and augmentations distort the appearance of the parenchyma and may also result in lumps and calcifications that are difficult to differentiate from malignancies. Can you turn that light off, please? It's just in my eye. Thank you. Maybe I can look here. This is an MLO view of both breasts, and it shows that the left breast parenchyma is definitely distorted with metal clips, denoting that the patient has some intervention. You really have to know the clinical setting of the patient before saying anything. Architectural distortion is a common mammographic finding after breast conservation and should be closely monitored. Any developing or changing area of architectural distortion should be viewed as worrisome. Patients may have early postoperative breast imaging to document possible residual calcifications, nodules, or masses. It's not obviously common that we do immediate postoperative mammograms. The post-lumpectomy mammographic findings are related to the time sequence of the procedure and can be classified into two general categories, acute and chronic changes. This is mammogram CC views of the same patient. The one on your left-hand side is an acute mammogram. It was done immediately following surgery. And the other one is several months later. Obviously, you will see that the breast is edematous and the density is increased. Several months later, all the edema has subsided, but the distortion of the parenchyma remains. Acute mammographic changes refer to the immediate postoperative period extending for the first several weeks and months. Acute changes include hematomas, seromas, and edema. This is the breast, the CC view on your right side. demonstrating edema of the breast, and you can see that there is skin thickening and subcutaneous fluid, best seen actually on the ultrasound on your right-hand side. Sorry. Yeah. This is the edema of the subcutaneous tissue, and there's a seroma also. This is another film of a large seroma in the breast. This is a small tumor in the left breast, CC view, and this is following surgery. And you can see the distortion. Obviously, you don't see the mass because of the edema, because it is gone also, and the skin thickening, probably following radiation therapy. Chronic changes refer to findings identified after the acute period, usually several months to years after surgery. These include scar formation, retraction, development of dystrophic calcifications, tissue asymmetry, and fat necrosis. This is an ultrasound image of a small seroma that is surrounding the scar, and I'm sorry, I'm not sure what is what. I'm going backwards. Can somebody please show me this? Okay. This is backwards. This is backwards. Yeah. This is the scar. Where is the pointer? This is the pointer. I'm not sure. ولا مكتوب. This one? Okay. This is the scar, and you can see fibrous bands developing within it. Initially, it's fluid, and you get fibrous bands that overcome the space. Eventually, the scar becomes narrower and denser. Yeah, this is a post-operative breast following the excision of this lesion. And it not only shows deformity of the breast itself and distortion of the parenchyma, but it also shows suspected calcifications posteriorly. And close magnification of this calcification demonstrates that it is mostly irregular, and it's dystrophic calcification, but it's very difficult, particularly if you have an excision of a malignant lesion, to say that this is categorically dystrophic and not a recurrence, for example. Most of the calcifications that you see can be attributed to fat necrosis resulting from the surgery and radiation. Suture calcifications can also be seen. Biopsy may be indicated when the calcifications appear suspicious or indeterminate. I saw this patient last week, and she had surgery 8 years earlier. And we've been following her up annually since. And here we see for the first time that there is calcification, which has appeared suddenly. And it is at a distance from where the scar tissue is. So this is a magnification view of the calcifications, and then we went ahead and did an MR, which clearly demonstrates that the calcifications are associated with fat necrosis. Another case where there is also clusters of calcifications at the site of the surgery, and it demonstrates a mass, best shown here, which is partly well circumscribed, but with a posterior attenuating shadow. These slides are not mine, but somebody a few years ago demonstrated the features, different features of fat necrosis, which can actually sometimes, like in this case, be quite confusing, particularly when they have posterior attenuating shadow like this. Some of them are solid, some are irregular. Some are partly cystic and partly solid, and so on and so forth. So I think keeping this in mind can make you, can reassure you at least as to what the etiology of whatever you see at the scar site can be. This is the same patient as you saw earlier, and there is a large area of fat necrosis here, which actually this patient came with a palpable lump, and this was fat necrosis, and we saw this on the, you can see that this is a T1 weighted image, T1 weighted image, and this is the fat inside of this lump. However, for some reason, the surgeon insisted that we should biopsy it, and we biopsied it, and it just turned out to be fat necrosis. And this is the difficulty. Sometimes those post-operative cases present with masses which are not really a recurrence most of the time. They're just different changes, which are benign. Some patients may heal with little or no mammographic findings. Luckily, the clinical history and placement of scar markers would be the only indicators of previous surgery. We always put scars over, we always put markers over scars. We put markers over the nipple. We put markers over palpable abnormalities, and we put markers over skin lesions so that we can correlate the mammogram better. This is a seroma. This patient had surgery maybe a couple of weeks earlier, and you can see the ultrasound showing a seroma, anechoic area here. But for some reason, there was some irregularity of the seroma. It should be, it should have straight lines. But it doesn't. The MR demonstrates that not only is the seroma wall is thickened, and there is an additional enhancing lesion just posteriorly. So this was a residual tumor following lumpectomy. It's not easy actually to see residual tumors, particularly when everything else is enhancing. Generally, hematomas and seromas have a thinner, smoother capsule, whereas residual or recurrent tumor is more nodular and irregular. This is another case, and there is a seroma on the mammogram, at least. And it looks different from the other side, but then operated breast will look different from the other side. And this is the pre-contrast. The pre-contrast T2 weighted image, STIR, not T2 only, FATSA. And the post-contrast image demonstrates this residual tumor. actually on ultrasound, you could see that this vertically oriented hypoechoic lesion is not consistent with the seroma. So MR was done, and it actually demonstrates that there is an enhancing mass posteriorly in the same location. Obviously, ultrasound and MR are then done in different positions. MR, of course, is highly sensitive, is a highly sensitive tool for detecting residual tumor. However, many papers have come up with what is the best time as to when to do the MR examination, and it is estimated to be between 35 and 40 days after surgery. This is if you're worried that there is residual tumor. Women with a history of breast cancer are at risk for developing local recurrence, a second ipsilateral breast cancer, or a contralateral breast cancer. This is a woman who had lumpectomy, which is of the right breast, and on annual mammography, this appeared, which was not present there, and I think it had some calcifications as well. MR demonstrates clearly that there is an enhancing mass posteriorly in the same location. This is recurrence. We have a lot of cases of recurrence. This woman had MR in 2003 and had a lumpectomy then. In 2006, she has even a much bigger mass on the same side and even extending to the anterior aspect of the breast. This is a woman who lived, I think, 100 kilometers away from where she did the surgery. And she came every year, but then she said it was difficult. And for some reason, I decided to do an MR, because those patients are really lost for follow-up. And what you're supposed to do after lumpectomy is radiation therapy. But then, because she lived away, very far away from Jeddah, maybe she could not attend regularly her radiotherapy sessions. So when I did the MR, she had extensive DCIS of this breast, and then subsequently she had mastectomy. So you have to be sure what patient you are doing lumpectomy on. You cannot do lumpectomy on every patient, particularly those who are not going to come regularly for follow-up. We've seen cases like this where the patient had a mastectomy, but the recurrence occurred in the chest wall extending to the pleura and extending to the rest of the soft tissues around the chest. This is another recurrence centrally here, and you can see it there on the chest wall. This patient had a mastectomy of the left side, and now she has tumor of the opposite side, and you can see the enhancing thick ring enhancing lesions in the right breast. Again, this is a case of lumpectomy on the right side and recurrence on the new lesion, actually, on the left side. Although breast conservation therapy with lumpectomy and whole breast irradiation has been recognized as surgical management for early breast cancer treatment since 1991, today more patients who are eligible for breast conservation therapy elect to undergo mastectomy instead. This is particularly important in the West, with marked increase in prophylactic mastectomy. A lot of patients are now electing to do mastectomy, and I think it's probably the right thing, particularly if you have multicentricity in 60%, as we were told, of patients. Oncologic reconstructive and cosmetic breast surgery has evolved in the last 2 decades. Understanding those new surgical techniques and their imaging features is essential for radiologic interpretation. Novel surgical techniques include skin and nipple sparing mastectomies, autologous free flaps, autologous fat grafting, and nipple areola complex breast reconstruction. So we really have to understand what is going on and maybe sit with the surgeons to have them explain to us exactly what. This is a patient who had a mastectomy, but with skin and nipple preservation. The ring lesion, the ring here denotes an area of distortion and calcifications. So here she had a tram flap, and the only thing you can see here, you lost all the parenchyma that you saw here. This is the tram flap, but the skin and the nipple are preserved. Preoperative MR imaging is necessary to evaluate disease near the nipple areola complex and to determine the patient's eligibility for nipple-sparing mastectomy. This is also a flap following partial. It looks like partial mastectomy because you can see that there is normal parenchyma here, which is regenerating. This is a patient who had reduction mammoplasty on the right and mastectomy with tram flap on the left side. An imaging finding of residual breast parenchyma should also be reported by the radiologist because of long-term surveillance imaging may be indicated. This is a patient who had recurrent, she first had a huge phylloidous tumor. She had a mastectomy and with a flap done. And then she had 2 recurrences in the flap itself, here. This is infection in the flap itself. You can get lots of infections and hemorrhages and some of the complications of flaps, reconstructed breasts. This patient had mastectomy on the left with implant inserted, and she had a lumpectomy on the right, on the left. Breast augmentation or mammoplasty has become increasingly prevalent in recent years for aesthetic and reconstruction in breast cancer patients. Early post-surgical complications are infections and hematoma. I'm talking about implant complications. Delayed complications include capsular contractions, implant rupture, gel bleed, rarely associated with anaplastic large cell lymphoma. Actually, this is the first time I see one with you. It's quite rare. These are 2 water implants, and they have ruptured completely. Which side is abnormal? The left side is abnormal. It's more rounded due to contractions of the augmentation. These are just some of the complications of, I'm not going to go through these because this is a long thing. And a lot of papers have been written about the complications of prosthesis. You have to make sure also that the prosthesis, not only there is something wrong with them, but also something wrong with the breast tissue itself. In this case, there was microcalcifications, 3 clusters of microcalcifications in the soft tissue surrounding the breast augmentation, and this was removed and a clip inserted. Okay. Yeah, I've seen also migration of the silicon to the lymph nodes, and this is what they look like. So these are some of the complications of prosthesis. Providing appropriate clinical history comparison with all diagnostic images and recognizing the imaging appearances of the post-treated breast leads to proper patient's management. Thank you very much.
The RSSA would like to present a certificate of appreciation to Prof. Asma. Thank you. Thank you for being with us. Thank you.
And also a small token of appreciation to Dr. Brkliacic. Now, their coffee and like small snacks will be served, and we'll resume at 10:20.